one-man army, Rambo. Baby walking like Naomi Campbell. I been like a sailor, swimming in the money. I was broke, won't go back. This a throwback, by the go in cold beer, baby, hold that. I'm not there yet, but I'm so close. Shine your light on me, I'm lost. Feeling around in the dark. I can feel it, I'm so close. I can feel it in my bones tonight. Move our bodies 'cause we own the night.
Welcome back to the Twist of Fate podcast, where you can find your inspiration to make your dreams come true. Today, I'm here in the Big Apple, Manhattan, New York. What you're going to learn, it's a special place for me and my guest when you look back at the historical context. We're not as young as we used to be. But today's episode is a special one. It's about not taking your health or the health systems of America lightly. You see, for me, as you all know, I've traveled internationally quite a bit. And despite what all the hype says, I think this is the only place in the world that I proudly can say that I would love to go to the hospitals, to our doctors. I have 110% confidence in that. Why? Because I know some great physicians. And I'm not just talking about my wife here. Today, we have Dr. Cioe Peña from the Northwell Health system is here to talk about what he's doing that's impressing so many people in global health and making us all feel better. Eric, my friend,
hey,
welcome
Doug.
to Twist of Fate.
Nice to be on finally. Thank you, Doug, for having me.
Okay, so Eric, for our audience here, maybe we could start off, you tell them a little bit about what you do in global health. And I mean, you're still a practicing physician. You still see patients, but you're helping people on a global level, and that matters. That really matters.
Yeah, so I'm really fortunate. I think I have the best job in the world. I'm obviously a little biased, but so I run and founded the Center for Global Health at Northwell Health, which, for those that don't know, Northwell is New York's largest health system. We're actually New York's largest private employer. And
I didn't know that.
Yeah, so we're big. We operate right now 21 hospitals. We have 80,000 employees, or team members as we call them, about 9,000 employed docs and 16,000 nurses.
All boroughs of New York.
Yeah, so Westchester County,
Nassau
and Suffolk County on Long Island, the 5 boroughs, soon to be Connecticut and the Hudson River Valley. So we're big and we're growing. We're kind of in a growth mode, as our CEO and COO call it. And I operate a really tiny part of that. So I operate the Center for Global Health, which is our global philanthropic arm, which really answered the question, if a health system, instead of a medical school or university, decided to do global health and do it with a development lens, how would we do it? And so I have a team of 6. So I always joke that there's 88,000 employees and 87,994 focus primarily on New York State, and we focus on the world. So we got to build Northwell's global presence and global programs over the last 6 years. And it's been a great journey. I also, like you said, I practice emergency medicine 1 day a week still at one of our hospitals. It's my day to relax and center again, actually. It's like the best part of my week sometimes. But building the global health program from the ground up has been a tremendous privilege at Northwell.
So first of all, respect. You are a frontline worker, and I don't know that respect and dignity are provided to all of our frontline workers. I thank you for your service.
Thanks.
And I love where you're going with this. So global health, for a lot of individuals, the healthcare as a business, it always kind of feels like like healthcare shouldn't be a business.
Yeah.
But everything in life is a business.
Yeah.
And trying to apply it in a global context. So what does global health mean? So like for a lot of my listeners that may not understand, right? They care about their health,
Right.
their communities. But I sense that it's very forward-looking to take how you're practicing medicine and teach others, and I'm assuming that you learn from them. So
Yeah.
I don't know if that's correct, but
No, absolutely. You've hit the nail right on the head. It's about creating partnerships, and the partnerships are not always kind of starting from a place of equality. And so it's thinking about how do we work with partners, and we've picked specific countries that we work in as our kind of initial partners, and we really are there.
Which countries?
We're working in Guyana, Ecuador, India, and Ukraine as our 4. We call them core sites. And we have 5-year commitments in all of our core sites, and we fully expect to renew them for another 5 years if the governments and countries will have us. And over those 5 years, our focus is really what they want to focus on. We meet with leaders, we meet with the ministers of health, we meet with the hospital directors in the public system, and we say, look, what are your pain points? What are the things that keep you up at night about taking care of your population? And we work on those. And we're almost like in-kind consultants, but with a heck of a lot of operations experience operating a health system.
What I find interesting is the countries that you mentioned,
Yeah.
quite diverse healthcare needs,
Yeah.
right?
Yeah.
You've got emerging economy needs, you have conflict and war.
Yeah.
So my assumption is that to the benefit of the patients of New York, right? Like,
Yeah.
you're sharing in notes, and then do you guys do summits, or like, how do the physicians learn? How do you guys interact?
So we have in 2 of the sites which have really taken off, Guyana and Ukraine, we have a near constant presence in the country, and we are interacting with the health systems in those countries on a daily basis. So in Ukraine, it's mostly telemedicine based and telemedicine focused. There is some in-country components of it. Obviously,
Means they have a surgical procedure going on, and you guys give counsel or advice or observe, or
right. Basically, so the idea is that we are the kind of second opinion, or I need to talk through a case, and instead of having a room full of orthopedic surgeons in Kyiv right now, every orthopedic surgeon, because of the war, is scattered, and they're kind of operating as islands because there's such limited medical resources to meet the overwhelming demand. So you can't have those call room conversations where you say, hey, look at this fracture. How would you approach this? So we become the call room. Like, we can have those conversations. Our orthopedic surgeons will talk through a case with their orthopedic surgeon. And often a friendship is formed. The information exchange is certainly bilateral. And honestly, what we found, ironically, is that the Ukrainians have way more trauma experience now, almost 3 years into this war, where they're giving us advice on some of the management of some of the things that they're dealing with and having to deal with. So it really becomes kind of a partnership. And then a lot of things come out from that. Like we realize that there are gaps, and there are educational areas, or there's mental health concerns. And we're able to fill those gaps with additional programming. It's almost like an ongoing continuous needs assessment. And then in Guyana, it's the exact opposite. We do a little bit of telemedicine, mostly into the rural communities. But right now in Georgetown, the capital of Guyana, there's Northwell staff working there. And we have a 365-day-a-year presence where there's somebody from Northwell working with the public hospital, with the government and the Ministry of Health, and the university system to further develop, a variety. We probably have between 12 and 15 departments and different specialties of medicine engaged with the Ministry of Health.
AI is a very interesting topic. The real American way is to embrace change. It is possible that many of us one day will work for an AI. Get used to it. If I wanted to invest in AI, what's the best way to play it? I don't know if you checked out the AI Drake is a better lyricist than the real Drake. Would you go to an AI church congregation? AI is coming, whether you like it or not. Invest in it. Get jobs in it. Embrace the change. Pretty amazing. So, one of the things I teach in my class is, create value every day of your life. Value for your family, your wife, your brother, your sister.
Yeah.
And in your case, what I'm seeing here from this global health, you guys are creating value not just for your patients, but you're making Northwell Health like a very competitive place to work.
Yeah.
Because you're getting these opportunities to interact with these countries, learn,
Yeah.
grow, but then also these countries benefit. So that's creating value for all, and that's what the name of the game is.
That's really the success, I think, of doing it out of the health system is, look, we're in a really competitive market. New York City is probably one of the most competitive health markets in the world. There are titans of medicine that have health systems here. And so we are offering an opportunity. And the fundamental question we asked was, we saw all of our physicians and nurses leaving the system to go do work internationally because they found it meaningful. And we said, well, what if we internalize that? What if we made that part of their Northwell job so that they got to scratch that itch, per se, through the acts of the Center for Global Health? And what we found was, not only did our physicians and nurses become, and other allied health professionals become more fulfilled in their primary roles, but the quality of what they were engaged with, because it was longitudinal and it wasn't this one-off volunteering with an NGO or the medical mission style trips, that it released the dopamine that they needed to feel good about what they were doing, but they were also part of really responsible, sustainable programming. So we're delivering better value to the international partner. And that was kind of a win-win, as you said. And it's taken off. It's been very successful. And I joke, there's 6 members of my team, but we leverage the 9,000 docs and the 16,000 nurses. And the great thing about working where I work is when I ask them for help in Ukraine, or I ask them for help with a project in Guyana, everybody says yes. Everybody wants to help. And they don't view it as extra work. They view it as work that restores their balance and their wellness to do their main job. And that's kind of a beautiful part of this.
Fantastic. And, a testament to your contributions and your team's work. I mean, you were recently acknowledged, if I'm understanding correct, right? In 2025, it's like a medical innovator award, or could you talk about?
So the Schwab Foundation, which is it's the Klaus and Hilda Schwab Foundation. So the executive chairman of the World Economic Forum and his wife founded this organization 25 years ago. And actually, it's a funny story. They founded the Schwab Foundation, and they said that we want to recognize social innovation in the world. So corporate social innovators, public social innovators, and then nonprofit social innovators. And they originally designed the award. They were going to give $1 million to the person that won. And the first cohort of people, they came and they said, look, we want to give you this money. And they said, we don't want money. We want a seat at the table. We want this Social Innovation Award to be an invitation to the World Economic Forum to meet with the titans of industry and government to help shape the future of the world. And so they said, we don't want any money. We want you to support us and cultivate us. So I was selected as the Corporate Social Innovator of 2025. So I'm now part of the Schwab Foundation. And the enormous kind of amazing part of that is not just the external validation and recognition, which I'm very grateful for, but it's also I'm now part of this community, and it's an actively curated community for 3 years. So I was at the forum this year. I got to attend the World Economic Forum. Next year, I'm going to be at Harvard Kennedy School of Government. We're doing a big program there where we do this kind of 2-week residency where we're part of the a special kind of course on change and social innovation from Harvard. And then we kind of stay active members of this community for life, but we're actively curated and kind of taken along for the first 3 years, which is pretty awesome. And in terms of opportunities and just being able to bounce ideas off of other people that are working in very similar contexts, or even honestly in different contexts, but working towards social good, it's been tremendously valuable. At the forum, I got to meet Muhammad Yunus, who's a special advisor to Bangladesh, Professor Yunus. And he like took me aside and gave me his cell phone number and said, if you have any questions, feel free to, this is the guy who like invented essentially microfinance, right, for the world, won the Nobel Peace Prize for microfinance work. Says, Eric, if you need any advice, give me a call. I'm like, that's amazing.
Eric, listen, I'm really proud of you.
Thanks, man.
I don't, my listeners breaking the fourth wall, looking at you. I knew this man over 15 years ago as a resident, busting his butt to learn and grow. And look at how much change has come, right?
Yeah.
That's incredible, Eric. I don't know if I hope I'm not the only one that has told you that.
No, but it's.
Have you even like stopped to like?
Yeah, take a breath and kind of look back. I mean, it's amazing. I mean, every once in a while. So I'll tell you one other story, one other anecdote from the World Economic Forum. So I got this. They have an app when you call Forum Live, right? And I get this like request on the app, and it says like HM Matilda is requesting a bilateral meeting with you. And I like go into her profile, and it's like the Queen of Belgium was like wanted to meet with a couple of the Schwab awardees to hear about our projects because she's on the board of the Schwab Foundation. But I took a step back and I was like, I'm a kid from Rhode Island who like did emergency medicine in Brooklyn and am now, interacting with world leaders. And it feels surreal. I have a couple pinch me moments, but I think it's important to remember, it's because the work that we're doing is valuable and it's valued, which is amazing. And it's really a testament to everybody at Northwell that has seen the vision of this, seen the possibility, and allowed me to grow it, and has supported me in growing it. And I tell people I've worked for a lot of health systems. I've worked for every health system in New York City, actually, and there aren't a lot of places where you say something that sounds kind of crazy, and people are like, "Yeah, go do it. See how it goes. See how it works. See if it works." I got a lot of no's in a lot of other health systems for things. There were a lot of reasons why you can't do something. And so the permission to fail, which I think a lot of entrepreneurs and people that listen to your podcast that are in the business side of things will know, having permission to try and fail and then stand up and try again is an enormous gift. I think some of the best innovations come out of that kind of culture of safety.
No question. I'm glad you brought this up, and I want to break the fourth wall on this one. Eric is bringing up a very important point for many of you that are thinking about entrepreneurism. You actually learn more from the failures than the successes. But I think in your case, though, from what I know, you don't fail very often. So this is another thing that, look, I give Northwell a lot of credit. Like I think they're giving that privilege to somebody that will take advantage of it and do well with it. So I just curious, because we go back a long way. Like, what even inspired you to follow the track and even be a physician at all? Like, you could have been a banker here. You could have done so many things here in New York City, but you chose to a life of taking care of people.
Yeah. I owe a lot of that. My mother is a nurse practitioner now. She's a PhD in nursing now, but she started as a critical care nurse, like a cardiothoracic ICU nurse for 20 years. Went to NP school when I was in middle school, so I remember her studying. I just loved, she'd wear a white coat and go to work and take care of patients. I thought that was so cool. I grew up during the AIDS epidemic, and so I remember learning about HIV, being very fascinated by the virus itself. There were people, I remember doing an independent study with my biology teacher in senior year of high school. And there were these people that were naturally immune to HIV. They had something called a CCR5, which is a receptor on your T cell deletion. And HIV couldn't enter the cell. And I was dorking out on that. And I did an independent study and I wrote a paper. And then I volunteered between high school and college in an AIDS clinic in Providence, Rhode Island, and saw people doing really well who could take their meds. And then there were a couple of people that had social determinants that they couldn't remember to take their meds on time. They had comorbid mental illness or something, and they weren't doing well. And then I realized that the drugs that were being paid for by federal legislation in the United States, the Ryan White Care Act, weren't available in the rest of the world. And it was still the number one cause of death in certainly in sub-Saharan Africa and Southeast Asia, but really worldwide. I think it was killing 5 million people a year at the time. And that injustice just struck a nerve. And so during college, I went into full activist mode. I linked up with a group called ACT UP New York, which had gone from...
What school?
Oh, it was at NYU undergrad. So
Great school.
Yeah. Good school.
Big shout out to NYU. We love you.
But I hooked up with these people at ACT UP New York that were really transitioning from domestic activism to global activism. And then I met Zaki Ahmad at an event. He founded the Treatment Action Campaign in South Africa, which was about forcing the South African government to cover the AIDS medications. And then we started seeing prices come down, and we started seeing people getting treatment. And now, we are actually at a precipice right now where if we redoubled our efforts, by 2030, we might not even see a new HIV infection in the world. And that's all because of public health. And so that was just so tremendously
the mortality rate
powerful.
Is just night and day from when.
It's a rarity.
People
honestly.
live with it.
And honestly, now people don't just live with it. People live with it with completely undetectable viral loads, so they're unable to transmit it. I mean, we are so far along. And it was because of efforts in global public health. So that was just, the ability to change the fate of humanity through public health was inspiring to me. And I knew I wanted to do public health, and I liked, and I still like, the individual relationship with the patient. The privilege you have to be able to take care of a patient. And in the ER, we always joke that, our regular day is somebody's either best day or worst day of their life. And that's a privilege. And it's an enormous kind of honor to be able to still do that. And so I still walk into the ER every week on a Friday. I usually work on Fridays, and I walk in and, it's just like, I feel like I'm home. I feel like I love that part of my week, and I won't give it up.
Are you an entrepreneur in training? Perhaps a business student seeking academic accreditation. Maybe you're a business leader trying to climb that mountain. See, I know I was one of them. Or perhaps you're a small business owner navigating the challenges economically of our time. Perhaps you're just a fan of the Twist of Fate podcast and myself, Doug Young. Well, today I have a proposition for you. Consider joining our exclusive premium membership subscription service called Twist of Fate Insights. You see, Twist of Fate Insights is an academic lecture series led by myself based on university curriculum that I've been developing as an adjunct professor over the last 5 years. For only $5 per month, you'll have access to this lecture series that will cover the areas of marketing, sales, innovation, and personal development. We have built this program around 4 key modules: where to play, how to win, when to adapt, and what to believe. Throughout these lectures, I'll be covering popular topics like AI and crypto 101. Also, how to fundraise like a champ, crowdfunding, and more. Twist of Fate Insights is my love letter to the special entrepreneurial community to make higher education more accessible, more affordable, and convenient for all. I hope you find your own twist of fate and the inspiration to make the world a better place.
They've asked me to.
No matter
they've
what
asked me
award
to, and
you
I
get.
won't do it.
Yeah.
Because it's just great.
So let me ask you. So you NYU, great school.
Yeah.
You had probably a pretty fun social life being here in Manhattan as a young man.
Yeah.
And then you decide to do the MCAT.
Yeah.
And then you start med school.
Yeah.
Now, where did you go to medical school?
University of Pennsylvania. UPenn.
UPenn.
Yeah.
So your mom's got to be like crazy proud at this point, right?
Yeah.
Like high point. But when you were there,
yeah.
Did you already continue exploring this global health, health inequality? So how at UPenn were you kind of trying to get your dose that you needed for that?
Yeah, well, I was one of the medical students, and there's a lot of medical students now that ask this. It's one of the top 3 requests of incoming medical students is, what are the global health opportunities in medical school? But Penn was one of those universities that very early on had that. So they had the Penn Botswana program. And so in my 4th year, I had the opportunity to go and do my clinical my sub-internship for 6 weeks in medicine in Princess Marina Hospital in Botswana, in the capital. That was a tremendous opportunity. I actually
had you been abroad before that?
I had been, so my summer between college and medical school, I had the privilege of working with a professor from Brown Medical School to set up the first electronic medical record in a clinic in Dominican Republic in Santiago. So it was a Microsoft Access based electronic medical record, that I helped digitize kind of all of these patient records that were on paper in 2005. So I had a couple, that was really my first formative global health experience. I had traveled before, I think I took an 8th grade class trip to Spain. But this was me working and living alone in a city in Dominican Republic, doing stuff that was supporting a health system. I mean, I was sold. I mean, that was, when I came back from that trip, I was like, global health's where it's at. I'm gonna do something this is gonna be a part of my career for the rest of my career.
And you picked up medical Spanish and...
Yeah, I started speaking, that's a funny story. I started speaking Spanish, I took it in grade school. And that 8th grade Spanish trip, I met someone that was like just a girl from like a club, like a little discotheque in southern Spain, and couldn't communicate with her because I hadn't taken Spanish classes seriously. And I was so mad at myself that I couldn't like talk, that I was like, I'm gonna learn Spanish. Like, this is ridiculous. Like, I should be able to learn. I've been taking classes for 2 years. I'm gonna take this seriously. So from like halfway through 8th grade on, I really, really tried to learn Spanish, and got a bachelor's in Spanish from NYU. Like you could, it was back in the day where you were pre-med, but you could major in whatever you wanted. So I majored in biology and Spanish American literature, and studied abroad in Cuba during undergrad, and just kept exposing myself to Spanish so that I would learn it. But I love it. I'm still bilingual.
My wife did the same thing, by the way.
Yeah,
she was medical anthropology, and then she did Spanish as well.
Yeah, so it's just one of those things where it's, there are certain people, and Nikki and I resonated with this too, is like, medical school is something that you do, but the pre-med part of it is just the boxes you check. But while you're there, do something that's fun. Do something, and honestly, even during medical school, like, there were things you had to learn, things you wanted to learn, and then things that kind of filled your cup while you were doing the other two things. And those are really important. And I was one of the students, I think my classmates would still attest to this. Balance was very important to me. Making sure that I didn't forget why I was there and get obsessed with something like grades was a very important part of my medical school.
No, I'm glad you're sharing this part of your development, because I'm not saying, I can't quote a statistic specifically, but I believe there's some perception that the practice of medicine isn't so rewarding for physicians anymore. At least when I teach at university, a lot of the young people, the prestige isn't always there. Yeah. But what I can see from your enthusiasm and passion, you made it like what you wanted it to be. Like, you already knew going into it what you wanted to do, but it's really great to see that. And then he's mentioned Nikki, my wife, which many of you on the show have seen her on here before. So then you met Nikki when you were doing your residency in Brooklyn, correct?
Yeah.
That's at Cook County?
Kings County. Kings County Hospital and
Cook County is Chicago, so it's Kings County.
Yeah. Yeah. I mean, it's Kings County, and it was funny.
And that's like a culture. Like, you guys party together, live together, like...
I mean, it's like
you guys. It's like a family reunion when I start to see some of these Kings County get-togethers.
Yeah, no, Kings County is a tight. I mean, you spend a lot of time with these people, right? Like, residency, according to the ACGME, is 80 hours a week, but you spend more than that with, maybe not doing clinical work, but with your class. And so, Nikki and I were in the same class, and you spend 100 hours, working with each other.
And so in emergency medicine, to the uninitiated, Kings County is like one of the number one places to train.
Yeah.
Why is that?
So
there's a reason why.
Yeah, I mean, it's the acuity, it's the volume and acuity. So Kings County Hospital is one of the busiest ERs in the country still. And it is resourced like a city hospital. And so there's a lot of reliance on the residents and the medical staff to do a lot of the jobs of healthcare, because they're just understaffed in nursing, they're understaffed in allied health professions. And so you learn so much so quickly, because you've just got an overwhelming number of patients that you need to take care of. And if you don't do it, there's no backup system or safety net. They just have a bad outcome. And so you work really hard. You work really hard, and you work together as a resident team. And the acuity is just, we'll have patients that, we used to joke that there's you get off the plane at JFK and come directly to Kings County Hospital to get treated. And so there's things that people have ignored for, a decade or it's just a community where there isn't a lot of other great healthcare, or at least there wasn't. And so the ER is the last line of defense. Like,
listen, this is my personal experience seeing the transformation that King County could do. I took the train when I used to live, to my audience, I lived at Wall Street and Broadway. It was a lot of fun. And I took that train to visit Nikki at Kings County one time only. I got off that train and I looked down some of the streets leading there.
Yeah.
And I go, if I walk down that street, I'm not coming back. Yeah. And when I visited her in the lunchroom, there was a gunfight in the parking lot.
Yeah.
And I started to understand that healthcare workers are not only fearless, like when something bad happens, you guys are running towards it, not from it.
Yeah.
I saw my wife go through that transformation, and I saw a lot of you guys that she would hang out, go through those transformations. And it's just, this is why I mentioned like that Kings County is a special place.
Yeah.
Like, and I've seen some of you we were in San Francisco at it was like was it a Kings County reunion?
Yeah, probably, the American College of Emergency Physicians, there's a reunion every year of all the county folks,
It's just incredible to meet that many people that will run towards a problem.
Yeah.
I made a joke with my finance head in my company when we were there. I said, if ever I'm gonna drop dead of a heart attack or get sick, it's in this room
at one of our
because
parties.
all these guys can save your life.
Yeah.
That's just special.
Yeah.
I'm so glad that you guys still do that reunion.
Yeah.
Awesome stuff. So now moving ahead, I think the quality of care in the U.S. system, we get a lot of criticisms, Eric. You know, people say all the time, like, our healthcare is expensive, or like, you know, our outcomes or mortality rates are like worse than like other places in the world. But I'd love to see your perspective on that. Like, I don't understand personally what these people are talking about. Because I can tell you, like, you've been to some remote places of the world, so have I. I'm here to tell you, I don't want to go to the ER there.
Yeah.
So, like,
well, I think we have a very interesting perspective because emergency medicine in particular, and what, you know, the umbrella that it falls under, which is acute care, has had a very different development story even in you know, high income countries like Europe than the rest of medicine. And so I think that my argument is that I agree. I think emergency medicine is probably the best developed in the United States and Canada, bar none. And I think that if you're going to have an emergency going to the US or going to Canada, you're going to have the best emergency care possible. And the important thing is what we've learned through the WHO and the Global Burden of Disease study is that probably about 55% of mortality and the global burden of disease is determined by how well you're taken care of in that first day of your health emergency, right? So the ambulance transport in the emergency department care matter a lot to how your outcome is going to be, right? You can have an amazing primary care system with amazing preventative care, but if you don't have a good emergency care system, and you get misdiagnosed or you get delays in care, you could have a really bad outcome, even though your overall health statistics, because you're preventing more disease, are good. So the way you even phrased it, if I'm going to go to an emergency room, the US is the place to be. The problem is that we've kind of got, outside of the acute care, we've got two systems, right? We've got the private, well-funded system, and we've got the safety net system, which is barely functional in terms of preventative care, right? I think emergency care, even in the public system, I think Kings County, if you're really sick and you're coming to Kings County Hospital, you're gonna get excellent care. You know, it's just, the problem is that in the US, when it comes to maternal health, when it comes to primary health care, pediatric primary health care, there are great docs doing amazing things, but the system needs work. And it's mostly about access. It's not the quality of physician. It's not how good we are at taking care of these people. It's how many touch points do we have, especially in low income communities, with those patients before they have a health emergency. And that's, I think, what affects our numbers a lot, is that we don't do a lot of preventative care, we don't do a lot of wellness care, and we don't do a lot of mental health care, and that all affects our numbers. And honestly, it's because we don't pay for it. Like that's the reality. Like people who say like, I don't understand why it's. I mean, I understand fully. You get the healthcare system you pay for, and if we reimbursed mental health the way we reimburse cancer, we'd have an amazing mental health care system in this country. We just don't. We don't do that. We've chosen not to do it. And I agree with you that I don't know that healthcare should be a business, but it is. And the people that want to sling mud at the payers or sling mud at the hospitals or the doctors, yeah, I mean, I guess it might feel good to do that. But the reality is it's been set up as a business. And until we change that functional paradigm to something different, we have to operate like a business. And so if the payers are, including the government, which is the biggest payer, doesn't pay or emphasize mental health care, it's hard to invest in that because it's just not being reimbursed.
No, I think, I'm glad you bring this up. I think a lot of people, when they think of healthcare, nonprofits, hospitals, and they see the business approach to it,
Yeah.
I think there's a lot of intimidation, mainly because obviously people talk about business and profiteering, but there's certain aspects in the trade of business, like having key performance indicators, quality scores.
Yeah.
These are things that, I mean, I think maybe the public doesn't even know, but you do have these KPIs in emergency medicine. You do have these things in hospitals. It's just that maybe it makes people uncomfortable, but I agree. I think at this point, nobody should shy away from accountability in your trade because it makes the trade stronger.
Right.
But that obviously helps when they got racehorses like you out there.
Right.
So I'm curious, like, health tech and, there's all these innovations, AI, robotics, in global health and kind of in your field, like, what are some of the things that are getting you excited or jazzed or kind of like, whoa, like this is totally out there?
Yeah, I think, certainly the interaction of technology with health is very exciting. And I think I think part of the mistake that I think people are trying to make, especially I get an email or a LinkedIn message from like a startup like every 2 or 3 days. That's like, I have an app that will do X, Y, and Z. And it's like, that's great, but if it doesn't interact with the ecosystem that is healthcare, it's just another silo that we're creating in a field of silos that medicine has created. And so the thing that I get excited about, that I think AI has a role for, and I'm really specifically excited about AI for this, is that we have 2 big problems in medicine. The first one is we have multiple disparate information sources that are all over scattered, and the patient doesn't have the energy to tie it all together, and the physician doesn't have the energy to tie it all together, but AI could do it easily. And then we have a lot of unstructured data from legacy, old, crappy systems, either whether it's a crappy EMR or a crappy program that managed weight loss, whatever it is. And AI does really well with unstructured data and structuring it. And so my hope is, at least in the high income world, is that we're going to start seeing a lot of these silos become interconnected, and we'll have like a physician assistant that is AI that can help tie this in for the physician, tie it in for the patient, and help create a better, more comprehensive picture of health. And then honestly, even in the developing world and in low and middle income countries, we've admired health equity gaps, wishing we had a solution. And a lot of the problems that were once required skilled hands to be at the bedside of the patient, and I'm thinking, for instance, like mothers in rural Guyana that are, the nearest health resource is 30 minutes away, and it's a community health worker. There isn't a physician. How do you bring great maternal care to that mother? And we're getting to the point where I can teach a community health worker how to move an ultrasound up and down the abdomen, and the AI is going to reconstruct all the images for me.
Correct.
So we're going to take the skill and make it so that you can be modestly skilled at the bedside, but be backed up by technology. That's a game changer. That's task sharing in a way that we could have never envisioned when we envisioned the idea of a community health worker, probably 20 or 30 years ago. And that's really exciting because I think very quickly with the responsible deployment of technology, you're going to see these gaps just close.
I'm really glad you brought this up to reassure some of my paranoid AI discriminators out there. that physician assistance versus physician replacement is what you view the future of medical AI-driven, AI-supported medicine can be. I'll tell you right now, like, just to keep it real, I ain't going to no AI doctor.
Yeah.
Not now, not 10 years from now, not 50 years from now.
Yeah.
Period.
Yeah.
And I think a lot of the concerns that people have, I'm trying to help them grow up a little bit, that, AI is here, but I love the fact that you're thinking of a world that it fits into what you're doing, and it makes you an enhanced physician or a better physician.
Yeah,
but
we can't be afraid of the technology, right? Like, and I think the best lesson is Star Trek, right? So Star Trek has AI, right? And even in Star Trek, like, there's still physicians, right? You may have a holographic physician that helps, but like, the idea that we're going to completely remove humanity from medicine, it's got, humanism must be in medicine. Even when we select for really high testing individuals that don't have people skills and we make them doctors, they don't succeed in the field. So it's not just about fund of knowledge recall. It's not just about being able to follow or even adapt your own algorithms. It's really about making a human connection and getting that trust in the treatment plan. And AI can assist with that, but I don't think it can replace it, at least not yet. And look, I always joke, I use the ATM analogy, right? Like, you don't go to a banker to withdraw money from your checking account anymore.
No.
You go to an ATM, right? But that doesn't mean we don't need bankers. Like, you still need bankers for high order things, right? And I think the same thing is true in medicine. Like, we're not replacing the physician anytime soon. And there's so much of medicine where all of the algorithms and decision trees told me I should send the patient home, but I didn't feel good about it. And something about the case made me a spidey sense. I still can't describe it to this day, and I kept them. And I prevented what would have been an out-of-hospital heart attack, and they had one in the hospital, and we were able to intervene immediately. I can't explain why I did it. I just did it. And there wasn't a piece of clinical data that was different. It was just, I didn't like the way they looked. And that's an instinct. And there's going to be that part of it. And then, look, our diagnostic radiologists are going to be doing the exact same job they did, 10 years ago in 20 years? No. AI is really good at reading x-rays and CAT scans. Really good. But radiologists are going to evolve to do something with that's even better. And I think that we have to be open-minded and embracing of this technology. Number one, because we need to be in the coding rooms talking to the tech folks. Because the one thing I have learned in the last 10 years is that you need the clinical leads to be able to explain, like, most people who are not in medicine or aren't married to doctors don't understand the inside workings of medicine. And when you try to apply a solution with limited data, it's not going to be as good a solution. So we want to be in the consulting booths and talking to people about what the need is and how to design the solutions. But I wouldn't be afraid of it. I think it's, there's reasons to be afraid of AI, but it's more kind of Terminator 2. Like, what are the Chinese and the US government, everyone doing with that part of AI? The medical part of AI, I think we're heading more towards Star Trek.
So I love it. I can say that, one, I'm glad you're not an AI discriminator. And I'm even more impressed that you're a Trekkie.
I am.
So maybe, is it Mr. McCoy, right?
Dr. McCoy.
Dr. McCoy?
I'm more of a Beverly Crusher. I'm more of the next generation.
Gotcha.
I like Voyager. Star Trek Voyager was a good show too. I love the Doctor was holographic, so I don't know if I could identify as much with the hologram. But yeah, definitely the next generation era, not the original series.
No, I'm sorry, man, but William Shatner is my man.
I know, he was amazing. He was amazing.
Is what it is.
Yeah.
But no, Eric, I really appreciate you coming on to Twist of Fate today. I'm sure I'm going to have either medical practitioners in training or students or even other physicians that perhaps this conversation opened their mind up of like how they can get more involved with global health.
Yeah.
If any of them would like to get in contact with you, like what's your method of how they could reach out? Like what do you prefer?
Either LinkedIn or you can just email me, ecioe@northwell.edu. I take time to write back to everybody. As long as you're not trying to sell me something on LinkedIn, like virtual assistants or something. Like I usually write back. Because I remember being the medical student writing people. I met Paul Farmer when I was an undergraduate, and he took the time to like stand aside and listen and answer questions for me, and it changed my career path. And I think that it's our responsibility to meet with people. What we have at Northwell in global health is very unique, very special. But I don't want it to remain that way. Like the idea is that this is a blueprint for how other health systems could do this responsibly. And if we all were doing it, number one, our physicians and nurses would be happier because they enjoy this work thoroughly, and we'd make the world a better place. So I'm happy to help share the secret sauce of what we're doing and talk to other leaders and other students about my career and my experience.
Love it, and I'm going to move into my final thoughts on this one. Listen, guys. If you're not inspired by Eric's story, let me at least bring to your attention. Eric didn't become a physician to make money. He didn't join Northwell to get rich. He didn't start medical school to just make his parents proud. His baseline assumption was he was resolving healthcare disparities. And in your own life, you need to think a lot of why you do the things you do. It's not the ends, it's not the getting rich part. It's more about having good fundamentals, hard work, good ethics, and a great heart. With that, I really hope you enjoy this content. Like, share, subscribe. We are bringing great American tales of entrepreneurism to you for free so that you can go out and make the world a better place. With that, I'll see you on the next Twist of Fate.
Twist of Fate is hosted by Doug Younger. It's produced by Julian Sepulveda and Zachary Davis at Mode of Motion Advertising and Film. Special thanks to all of our Patreon members. And if you want to be a part of our growing community, join our Patreon and get access to bonus material, Twist of Fate merch, and more. If you enjoyed this episode, please like the video, comment, and subscribe. Thanks for listening.